Hello, welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. Starting back in September, we changed our Grand Round Series to a webinar format, and we've tried to do this most weeks and cover topics including education, clinical topics, development-related topics, research, and research topics. We have two sources of funding for this series, and there are many people who work on this, including Samhar Abraha, who's corresponding with speakers weekly, working on this really most days out of the week. I want to reemphasize the importance of post-evaluation feedback. I've appreciated getting comments about the series, about individual presenters. I read every comment and look at every response. It's very helpful. I often share results with presenters. I'd like to encourage you to complete the evaluation afterwards. Thank you. For today, our presenter is Dr. Doug Zatzik, who's a faculty member here at UW. Dr. Zatzik completed a Robert Wood Johnson Clinical Scholars Fellowship in 1996 and later joined faculty at UW in 2000. And became a professor in our department in 2009. At UW, Dr. Zatzik's appointment has been at Harborview Medical Center, where he also served as medical director of the CL service for many years. Dr. Zatzik has over 2 decades of research focusing on development and implementation of screening and intervention procedures for PTSD, alcohol use disorders, and other conditions in trauma care systems. One point to note, in 2009, Dr. Zatzik was the chairperson for the NIMH study section on services in non-specialty settings. And another point about mentoring, Dr. Zatzik has closely mentored, it appears, many UW faculty, residents, and fellows, and dozens of graduate and undergraduate students. That's been a big component of his work and career. Dr. Zatzik is currently co-leading an effectiveness study comparing 2 models of care for individuals who are acutely injured. We'll hear not only a synthesis of this work, but maybe some about current work as well. So I'll stop for now and have Dr. Zatzik share. Thank you.
Thank you, Joe. Well, thanks for that intro, and let's see if I can get the share screen up. And can you see that?
Yes.
Perfect. Okay. All right. Well, Joe, thanks for that intro, and thanks for the invite to Grand Rounds. It had been a while, and so I thought this would be a good opportunity, virtually as it is, to catch the department and folks up on what we've been up to with the TSOS research program. Multiple public funding sources, nothing else to declare, and just a great group of collaborators. This is our current group. A couple of folks, Ron Mayer, Surgeon-in-Chief at Harborview, and Joan Russo, who's emeritus in our department, have been with us the full 20 years. So special thanks and call outs, but to the whole group as well. So just a bit of an overview before diving into the details of the talk. I thought we'd start with the question, why trauma survivors outcomes and support? Why TSOS? Why systematically look at screening and intervention and referral for PTSD, substances of abuse, and trauma patients? And I think we'll find that there's just tremendous individual suffering at the nation's, usually safety net trauma centers, and that there's just a ton to do in terms of figuring out the screening and intervention protocols. I think we'll also see that it's a unique service delivery setting, trauma care systems in the US, and there's a real chance for clinical trial data to inform policy. So after that intro, we'll dive into the first sort of decade or so of alcohol trials and look at sort of the policy that the American College of Surgeons has formed around the alcohol trial evidence. Then we'll look at PTSD over the past couple of decades, and one of the impetuses for this round is we've just finished a 25-site US Level 1 Trauma Center trial targeting PTSD and comorbidity. So I wanted to talk a little about those results. And then also, you can't really do anything without COVID these days. And, there was a great talk last week by Rebecca Hendrickson, and we'll just sort of in a cursory way talk about COVID, but think about that filter for U.S. trauma care system policy. And so the sort of disclaimer or caveat in all this is that we'll be moving at about a study a slide, and so I'm going to sort of be painting broad brushstrokes, but I'm hoping to leave a fair amount of time for questions. So if anybody wants to dig deeper into any of the particular studies, we can follow up during the question and answers. Also, I'm here at Harborview, so at any point if people have questions, happy to answer them. So why TSOS? Well, in terms of traumatic injury, folks who come into trauma centers, which, as I said, are often safety net hospitals like Harborview across the country, really have all sorts of difficulties after the trauma: PTSD, depression, suicidal ideation. There's also sort of risk behaviors and alcohol and drug use that go into sometimes higher likelihood of ending up at a trauma center with a traumatic injury. And our populations are often low income, diverse folks who have multiple adversities, sort of the negative end of the social determinants of health going before the trauma, this trauma that brings folks into the trauma center. So tremendous individual suffering and a lot to do in the wake of traumatic injury. There used to be sort of a joke at trauma centers, and it's still, there's a sort of some cynicism, we saved your life, what else do you want? We're just going to send you back into the community. And it's sort of like sailing off a flat earth, into the abyss. And so TSOS, the little emblem, it's a life preserver. So we're trying to help people as they sort of try to get back into the community and sort of help them float a bit in the care transition. This is just, a slide reminding folks, this is a epidemiologic survey done about 2010 or so, 2012, where we randomly sampled, 900 patients on the Harborview trauma wards, and, 70 to 80% had one problem or another: PTSD, depression, suicidal ideation, alcohol, other drugs. So it's really a highly comorbid, challenged population in terms of psychiatric and substance use comorbidity. So this timeline that's adapted from a paper we've got coming out in medical care pretty much, shows you over the past 20 years that the arrows are trials, pragmatic, I can call them comparative effectiveness trials. The rectangles are ACS-COT policy, and there's actually, to get this all on one slide, we had to take out one triangle. And then the circles are policy summits that we convene now at the end of every pragmatic trial, so as to translate our trial results within the 5-year period of the trial, rather than, it's our way of sort of reducing the time lag on trial results getting into policy and trauma care systems, healthcare systems. One note here, we had to postpone a June 2020 summit because of COVID, and we're having that later this spring. So that's the 2021. So outside of the individual suffering, we're in a really unique service delivery context in that the American College of Surgeons puts together every 5 or 6 years or so a resources guide, okay? And these manuals drive trauma care nationally. You actually, if you want to be a ACS-COT accredited trauma center, you have to sort of attain these principles outlined in these guides. And there's a very sort of systematic process, almost like a PDSA cycle, plan, do, study, act. It's like a revision process where the college puts out criteria. There are verification site visits. The criteria reviews, and if you're looking for the principles for revision for data-driven, actually the college is very open to single and in particular multi-site pragmatic clinical trials in terms of informing the next round of resources, guides, requirements. These are requirements. You can get to the level of requirements. Sometimes they're guidelines, but they're requirements, and then the college comes by every 3 years and makes sure they verify that you're doing at your trauma center what's required. So a very unique sort of make it happen health service delivery context, which I think, so why TSOS, tremendous individual suffering, but in particular the randomized comparative effectiveness trial is a tremendous tool for driving change in trauma care systems. So, before diving into the Harborview trials, just have to take a step back. I mean, I'm talking about, 2000, but really a tremendous amount of work done by pioneers like Wayne Caton and Jürgen Unitzer, 25, 30 years ago to get collaborative care, which is our main intervention approach, into general medical settings, into primary care. This really was foundational in terms of pioneering PTSD interventions and comorbidity in acute care settings. So really, we couldn't have done it without this groundwork in the 1990s and early 2000s. So diving into alcohol trials. So this is a paper with the lead author, Chris Dunn, who's a psychologist who was here at Harborview and has retired now. So I'll be showing you a lot of graphs, okay? So essentially on the x-axis will be months post-injury. The 0 months now is a time before injury on this graph, and going out to 12 months post-injury. And on the y-axis are symptoms. So here it's alcohol use, okay? And what Chris and our team is showing in this paper, in a prospective cohort study from data derived from UC Davis, about 100 patients, is that immediately after a traumatic injury, there's a dip in drinking, okay? And then a gradual recurrence over the course of the year after injury. Now, this has been called a teachable moment. In some cases, folks are, have a bad lower extremity femur fracture, and they're in a skilled nursing facility and they can't access alcohol. Okay, so that's an instance where you're in a setting where you can't get alcohol, but often there is sort of a teachable moment, a reconciliation, a realization that, hey, I was in a crash and I almost died and I was alcohol intoxicated. And so that set up a series of clinical trials with a brief motivational intervention at bedside in the surgical ward. And this is in the Annals of Surgery. This is actually 1999. This is before I came to Harborview. You have a team. Chris Dunn is the interventionist. Rick Reese is on this paper. Larry Gentilello is the lead trauma surgeon. Dennis Donovan, Fred Rivara, Jerry Jurkovich, just a fantastic team. This was an NIAAA R01. And what do we see? So Chris does a 30-minute, this is essentially an efficacy trial. PhD clinical psychologist delivering a 30-minute bedside motivational interview, sort of, coming first to the fact that, or, noting that alcohol was part of the crash, part of the injury, and then weighing the pros and cons of drinking, right? In a non-confrontive motivational interviewing sort of style. And Chris Dunn was a master at this. And what do we see? So now we've got the graph with the x-axis, 12 months post-injury, y-axis going up is more alcohol intake. Blue will always be intervention, sort of orangish yellow will be control. So in the control group, we see the dip in recurrence of drinking that we saw in the prospective cohort study. Here, the dip occurs at 6 months, but by 12 months, folks are back to their normative, pre-injury drinking. In the intervention, 30-minute bedside intervention by Chris, you see a dip and a sustainment of reduced drinking over the course of the year after the injury, okay? So the next trial was 120 folks. This was actually funded by a K award. It's our first go at stepped collaborative care with a motivational intervention element embedded, so a behavioral intervention, if you will, element embedded within frontline care management. So Chris Dunn trained, Roseanne Drosch, who was a social worker who had just graduated from the UW MSW program, and she delivered the 30-minute bedside intervention, but also did boosters. Okay, so basically, what did that look like? So a patient would come into ortho clinic, first floor of Harborview, and what they would do is, they say they're in a wheelchair and they need to go for X-ray, and that might take an hour or two. And Roseanne is helping them get to X-ray, and they hit a bump, and the patient's like in pain, clearly, understandably, and they say, this is when I need a drink. So they settle in at X-ray, and then Roseanne has, it's an opportunistic intervention. She has time to mull over, the pros and cons of having a drink in terms of self-medicating for the pain or any other sort of injury sequelae. So we had both the bedside interview and boosters, and we had a highly effective, again, you see the dip. This is more of an effectiveness trial. There's other intervention elements going on, and we'll see that later when we look at PTSD, but you see the dip in recurrence in alcohol in the control group in the orange line, and you see the same sort of dip in maintenance of diminished drinking over the 12 months in the intervention group, the blue line. So, following this timeline, we're now at about 2006, and the rectangular symbol here now stands for this, our first sort of alcohol policy requirement, okay? So based on a series of single site trials, most of them at Harborview, I think there were 3 trials, the American College of Surgeons required level 1 trauma centers to screen and intervene for alcohol. In other words, if they come at 3 years, the verification site visit, and you're not screening and intervening, you get demerits, and you might not make criteria for accreditation by the college, and there's a whole process. It's shameful, and you lose funding. So this is a big deal. At level 2 trauma centers, you just have to screen, and then every 3 years the college comes and verifies that you're doing screening and intervention. So there was a lot of pushback. This is an unfunded mandate. From an implementation science perspective, well, is this being innovative, or even pushing the early adopter piece, or are you guys mavericks? In trauma care. This is a paper by Rich Sates, who's a prominent substance use researcher. He's an internist at Bernstein's an ED doc. And there was a lot of pushback on this. So our team decided to apply for, and we got an NIAAA R1 grant to do a multi-site parallel group cluster randomized design, the Disseminating Organizational Screening and Brief Intervention Services trial. Okay, and what did we do? So 10 of the sites were randomized to control in the parallel group design, and they did mandate as usual. Okay, everybody had to do this. Okay, but and in the 10 intervention sites, we did an organizational intervention followed up by ongoing feedback and coaching by Chris at the sites. A real light touch. There was some work by Will Miller suggesting workshop plus feedback and coaching was most effective in terms of a dissemination implementation strategy for alcohol. And so it was a very light touch. It wasn't a ton of feedback and coaching. Okay, and that's what. So the 10 intervention, everybody offered up the folks who would be implementing the mandate, and Chris did the feedback and coaching with those folks at the intervention sites. And what do we find? So we see the voltage drop characteristic of many implementation trials, but we still see the same pattern that we saw in our efficacy and effectiveness trial. Essentially, in the orange usual care group, you see a dip and then a flattening of drinking from 6 to 12 months post-injury. But in the intervention, you see the dip and actually a continued decrease in drinking. And this is clinically and statistically significant. The effect size here is about 0.2. So not a modest effect size, but nonetheless, this is sort of frontline trauma providers, a little bit of training and coaching. And at the end of the day, along with some other data on injury recidivism and some data from some other sites, this pushed the college to a universal, upping the mandate to universal alcohol screening and intervention at all level 1 and level 2 trauma centers. And still a verification site visit every 3 years. This is the orange book. This is 2014. So we've done subsequent sort of studies of the quality, and there's the quality of the alcohol intervention rollout and even the sort of verbiage in the resources guide describing what passes allows for tremendous variability in what's done. Okay, here at Harvard, there's still a bedside motivational interview done by the Addiction Intervention Service. But at other sites, it can be just handing a card out, talking to people about alcohol, and it doesn't have to be an MI style, a brief negotiated interview, but and then a referral card, can cut the mustard. Can get you by your site visit. So it's tremendously variable. There's some other aspects of this that come under question, and it's sort of something we'd like to come back to with the college at some point. So moving now to PTSD trials. We're here in our timeline about 2000, 2006. And going back to that initial 120 person comparative effectiveness trial, we also, it was multifaceted, and we included sort of evidence-based PTSD treatment. But there's a rub. In the first 3 months post-injury, we had Roseanne Drosh, our MSW, was basically very interested in sort of providing support. And we have a pretty much an unbreakable sort of first question we ask everybody: of everything that's happened to you since your injury, what concerns you the most? Which, but it's both an open-ended question, and it targets for therapeutic alliance the patient's primary concern. So you could be in pain and you get help from, the care manager will go to the nurses and talk to them, and you might bring in a psychopharmacologist or an anesthesiologist to adjust pain, pain control after injury. You could be sort of, after your pain is controlled, you may be losing your apartment because you're in the you're at Harvard, you're unable to pay your bill, and we'll deal with that, right? So those first 3 months, we let Roseanne basically just continue to ask about concerns and address them. So no evidence-based PTSD intervention. And then at 3 months, Amy Wagner came in with session-based cognitive behavioral therapy, exposure-based therapy at the time, and I was the psychopharmacologist, okay? And so what we see is there's a significant effect here, mostly because the control group is getting worse, okay? And you see in this trial, because it was a combined trial, alcohol and PTSD, not everybody had to have PTSD. In other words, and in fact, not everybody did have PTSD. Only about 20% had symptoms consistent with PTSD at baseline. So what happens when you look at 3 months to the folks that Amy and I brought in the evidence-based psychopharm and CBT interventions with? Then this begins to look more like an efficacy trial. There's only about 30 folks in 15 in each group here, and we lose a lot of people in these trials. It's hard to follow up with our samples, so probably even less than that. But you begin to see sort of what looks like more of an efficacy curve, or a set of efficacy trajectories, where the control group is coming down somewhat, but the intervention group has about a 20% diminishment by the end of the year rate of PTSD. Okay, so this inspired us to write an R01 grant, and we got an R01 funded, and we screened twice for PTSD in the R01. So the very high PTSD checklist scores compared to the sort of pilot trial. So high PTSD symptoms early on. Okay, here we had 12 months of study team intervention. So this for us is a Cadillac intervention. 12 months of collaborative care intervention over the 12 months after the injury, okay? And what we see is, very nice treatment effects at the 6-month post-injury time point, about 0.55, 0.65 on the PCL. And by 12 months, you see a diminishment about half of that, treatment effects at 0.34 or so, but highly statistically significant group by time interaction over the course of the year. And maybe even most importantly for our trauma surgeons, we looked at SF36 physical component summary scores. So with the PCS, we've been showing you all the graphs, worser is higher on the y-axis. Here, 100 on the physical components summary score, which is things like bowling, getting around in your community, orthogonal to psych symptoms. Basically, but it's still a self-report, which the surgeons have some problems with. But essentially, 100 is an excellent health state. 0 is really almost a state worse than death. What we see is about a 5-point difference at 6 months, which is, it's like losing a chronic condition, like losing diabetes. And by 12 months, the difference narrows, but still a statistically significant group by time interaction effect over the course of the 12 months after the injury. Okay. So it's often hard, in our collaborative care trials, we put everything together. So it's often hard to dismantle, although you'll see we've made efforts to do this. But in this trial, in the R01 trial, basically medication adherence, both the SSRIs and insomnia meds, were strongly associated when you compared intervention and control group self-reports of whether or not they were taking medications, antidepressants for an adequate period of time. And insomnia medications. The intervention patients had significantly increased adherence. Okay. Now, at the time, we were not using SNRIs and Lafaxine, duloxetine, and important efficacy work has come out since then. This is a paper by Jesse Fan and colleagues in JAMA Psychiatry showing us the SNRIs are also effective in terms of post-injury depression, we think PTSD, and also disability. So now we're using SNRIs as well, but we didn't in the 2013 trial. Session-based CBT has always been difficult for our team to attain, and getting our patients to office-based CBT it is the treatment of choice. You look at the Cochrane guidelines of Jonathan Bissen, and you look at it, but it really is challenging for our patients to attain. And we started to draw these consort diagrams for CBT sort of introduction, entry, and completion. And consistently across trials have found very few patients, 8 to 12 sessions. We're lucky to get, a tenth of the sample in for 4 sessions, very, very challenging. So what did we do? So our next trial, this is a 2015, a PhD level psychologist, was basically took CBT and made it into sort of bite-sized elements like motivational interviewing that could be delivered within proactive care management. And what do we find? Again, intervention is blue, usual care is control. We found a similar effect size, 0.34, which for us is, we're happy with that. You'll see later on, you know, our patients, we don't cherry pick it. It is really a hard to read population. So 10% opioid use disorder, 28% alcohol positive, 4 serious prior trauma. So, you know, the blunted effect sizes or the diminished effect sizes we're used to. And this to us was a very pleasing result that we could sort of take CBT and put it into elements and deliver it. And in fact, Diane Darnell did a dismantling study and showed that really what was active in this trial was the CBT elements plus homework completion in terms of PTSD symptom reduction. These observations about the breadth of applicability or reach of CBT led to a series of more theoretical papers led by Tom Kepsel, who's since retired, on sort of population impact and combining estimates of effect size with reach in our populations to really come to an overarching construct population impact, which is our preferred outcome assessment. Now, John Fortney, others have used this on the DoD group, Brad Belcher, Mike Freed have picked this up in the Steps Up trial. John did some exploratory work also in a VA hybrid type 3 trial looking at telemedicine-based care management and population impact. This is a great meta-analytic review by an Australian group in Melbourne. Belinda Gabby and Melita Gumara has taken the lead on it. It basically is, it's in Clinical Psychology Review, I think an excellent journal. It basically, you know, does both a meta-analysis of treatment effectiveness and incorporates the population impact reach assessment and finds what Jonathan Bisson and all the Cochrane reviews find, you know, which is that session-based CBT has the greatest treatment effects and effect sizes. But if you throw in a population impact and reach assessment, then stepped collaborative care is the early intervention of choice. Really interesting paper, 2017 Clinical Psychology Review. So based on all this, we have made a recommendation to the college. You know, this is back a few years now, 2014, for PTSD screening, intervention, and referral. It did not attain, like alcohol, a requirement level, but this is in the 2014 resources guide based on a policy summit that we had with the college earlier. But you know, the college is interested in multi-site intervention trials, especially if you're going to attain requirement level recommendations. So here's where we are. And after the 2014 Gold Book, we you know, applied multiple times and obtained funding for a 25-site pragmatic step wedge cluster randomized trial. And this is the trial we've just finished. Basically 25 US level 1 trauma centers, 635 patients randomized step wedge design, which instead of the parallel group cluster randomized design in the USBI trial, here each site begins with the control condition and you randomize sites to switch on the intervention. So we asked sites to recruit 40 patients total. So a first group of sites recruits 8 patients, it's controlled, switches on the intervention. Next is 16, 24, et cetera. And you're randomized to when you switch the intervention on. 3, 6, and 12-month telephone follow-up, usual care control, and step collaborative care intervention. Again, taking to make this sort of, you know, as real world as possible. This is coaching and training to frontline trauma center providers. So the sites think about who they want their PTSD teams to be, and they basically put them forth as folks to be trained. So this could be, we have some sites where trauma surgeons took the lead, other sites where nurses, social workers, you know, whatever amalgam of providers the sites came up with, that's who was trained. Just in terms of who gets, and this is characteristic of our single site trials as well, a remarkably diverse, multiply traumatized patient population. About half folks were female, half the folks were white, about a third were Black. 20% folks in this trial, firearm injury survivors. So about 130 firearm injury survivors, most 2/3 public or uninsured. This was during Obamacare in the aftermath. So, there's charity care that comes in for some of the uninsured folks, but some first-generation Americans who actually don't have any coverage, immigrants. So 28% alcohol positive, 10% pre-injury opioid use, and on average 4.5 serious prior trauma before the event that brings folks to the trauma center. So really a multiply traumatized, multiply comorbid population. The intervention, okay, step collaborative care, empathic engagement of everything that's happened to you since the injury, what concerns you the most. I'm in pain, okay, we'll address that. I'm losing my apartment, okay, we'll address that. Well, I'm having nightmares, or every time the door slams, I think it's a gunshot. Okay, early on, up front in the surgical ward, both medications targeting PTSD and comorbidity. I mean, some folks are so affectively overwhelmed, it's hard to lay down new verbal learning. It's hard to have conversations. Early psychopharm, okay? Also behavioral interventions at the get-go, okay? Both the motivational interviewing and the CBT elements, okay? For those folks who with persistent symptoms, after the first few months, specialty referral, and community integration. At the end, this was 2 hours of frontline provider time. It's something to hold in mind when I show you the results. And most of it happened in the first 6 months after the injury. So what did we find? So this is the results. Very interesting, from a number of perspectives. So let's first look at this baseline difference. What happened here? Okay. So remember, stepped wedge, we are not in a parallel group design. We have the stepped wedge design where everybody begins as control, okay? And a certain number of the sites may have learned, okay, so the control group has lower symptoms at baseline, and they may have learned not just how to intervene when we come and do a one-day workshop at the end of the control period, but also how to screen for PTSD, okay? Now, you show this to sort of typical, PTSD efficacy researchers, and the initial response is regression to the mean. Well, we've done a series of secondary analyses that, from an implementation science perspective that I'm about to show you, that really, I think, argue strongly against regression to the mean as the explanation for these results. So let's just first look at what the results are. So when you look at the differential time effect, the net change over time, you see basically a 2 to 3 point, 2.57 points on the PTSD checklist reduction. Modest, the effect size is 0.18. So for 2 hours of frontline interventionist time over the 6-month post-injury, you have a 0.18, 0.2 effect size. Okay. And then at 12 months, that goes away. All right. And basically you have a sort of widening of the difference and no significant effect. We had hoped for a 12-month effect, even though the PTSD intervention is really only 6 months. Now let's sort of so as part of this trial, we had an implementation process assessment. So what did we do? We basically embed sort of eyes on the ground in terms of the clinical team rolling out the trial. And we're touching bases frequently with our mixed methods specialist, Larry Palankas, and talking about the barriers, facilitators, and other characteristics that are sort of really prominent to this particular pragmatic trial. And let me tell you, it can really vary across trials. These pragmatic trials are these huge efforts. There's multiple sites, and each trial has its own sort of idiosyncrasies, okay? So quality of intervention delivery is something we're going to be watching at every site. Three characteristics. Can you do proactive care management? Do you have a psychopharm competence? And can you deliver the behavioral therapy elements? Okay, so that's sort of the intervention quality piece. But then we wanted sites to recruit 40 patients. 32 to 40 were excellent sites, 24 to 32 good sites, fair sites, 16 to 24 poor, so everything sort of, did the leaders stay long enough, to really oversee the trial in a stable way, or did the team have to go out and do an intervention site visit when there was a sudden trauma surgical leader turnover? Okay, regulatory compliance. Each of these domains that were observed to be of importance in the rapid assessment procedure and from clinical ethnography were then brought to bear and made into a scale. Thank you, Joan Russo. 0 is poor and 3 is excellent. So if you recruited 12 or less, you're 0, right? If you can't do any of the PTSD collaborative care intervention elements. That's 3. If you do all 3, they're excellent. Okay, and we dichotomized fair poor sites. There were 13 of them. Had, I think, 2 or less, and 2 are great. A score with 3 is excellent, and 2 is good. 2 or greater is good, excellent. Okay. What begins to happen when we take the sample and stratify by quality of protocol implementation? You see then that the baseline difference in the fair poor group is accentuated, and there's a narrowing in the good excellent group of sites. And basically, the idea is that the good excellent sites kind of know about PTSD screening and are doing better at the intervention, and they're having markedly improved effectiveness. While the fair poor sites, as I'll show you now, there's even a hint that at the end of the day, at the end of the year, the control group is getting better at the fair poor sites, and the intervention group is sort of staying the same. It's a trend. It's not the whole sample, but here a 0.1 effect size is not statistically significant at the 12-month time point. The interventions, the good excellent sites have, what we had hypothesized at 6 months of 0.31, we had powered this to 0.34, and by 12 months, still a statistically and clinically significant 0.26 effect size. So, 4 points, 5 points on the PCL, about 4 points on the PCL. Interestingly, very challenging population, but increasingly relevant. The 130 folks, firearm injury survivors. Okay, they're very, for a good excellent site, like there's not a lot of discovery work that it takes. It's an injury type, and you come in the morning and your firearm injury folks are clearly identifiable. So finding folks with high PTSD symptom levels who are firearm injury survivors is not an issue. At the good excellent sites, there's among the largest subgroup effects. We have 10 points on the PCL at the 12-month post-injury, which is similar to our effectiveness trial, and so really marked clinically and statistically impactful treatment effects among the firearm injury cohort at the good excellent sites. Okay. Where does all this sort of lead us in terms of this sort of pragmatic trial to policy interface? Well, we've been so focused on getting a requirement with the college that I think we've underemphasized the verification site visit. So while the requirement sort of balances you and gets you into sort of reach, you mandate something and everybody's going to do it. Everybody is doing alcohol screening and brief intervention nationally, okay? But the quality of the intervention really is left up to what's in the resources guide and what happens at that verification site visit. So, this is something I think we need to sort of hone in, and it's a series of discussion. You cannot have your entire day verification site visit devoted to PTSD and alcohol. We understand that. But is there more we can do to ensure fidelity to what we think are evidence-based interventions? Otherwise, if we just mandate collaborative care for PTSD, there's a good chance you do it poorly and you may even not help patients, but possibly even make things worse, right? Complicated patients. So I just want, fantastic rounds last week by Rebecca Hendricks, and this is really cursory in comparison to that talk. And, but I just wanted to speak a little bit to COVID because in this upcoming policy summit, and just day in, day out, we are dealing, right? So this rapid assessment procedure informed clinical ethnography that I described, it really derives from study team experiences with disaster mental health, okay? Where you're in a disaster setting and you're embedding participant observation in the frontline disaster relief folks. And they're reporting back on a regular basis to an expert mixed methods consultant who may or may not be on site. Okay, and the emphasis here has always been rapid project completion. Okay, this is not something that takes months or years of in-depth qualitative coding, but sort of crystallization, immersion coding, more rapid coding, coming up with themes that are then directly reapplied to the disaster relief efforts. Okay, so what we've been doing, I think as Joe mentioned, we have an ongoing comparative effectiveness trial here at Harborview looking at peer integrated collaborative care. we've now embedded RAPIS in every trial we do. Okay, so this is part of the protocol that we have frontline clinicians making, logging field notes and jottings and checking back in with a mixed methods consultant. Here, you can focus towards sort of bread and butter implementation science issues like protocol modifications and adaptations. So that's what RAPIS would be doing day in, day out. Well, then disaster strikes, right? So, where are we? I guess we're at the dotted line anniversary reactions, February 29th last year, March 1st, we're on the verge of February. So, this is sort of the pandemic in a nutshell. And you tell me where we are in this. But back in March of 2020, we were sort of in the heroic phase. And because this is part of our protocols, like it's not even a pivot, it's just flipping a switch to take your field notes and observations and apply them to what you're seeing in the first couple of weeks of March. So we did this, our team did this, okay? Our participant observation was moved from whether or not there was a modification in the peer-delivered intervention to what we're doing for COVID, okay? And so rapidly, we come up with primary and secondary COVID prevention strategies, which are just it's low-hanging fruit. You have a patient coming in with an orthopedic injury from Eastern Washington, they're helicoptered in and they're going back to Eastern Washington. It's not uncommon, it's almost standard practice for Harborview to bring that patient back to ortho clinic, 3 weeks, 4 weeks out. Well, now you've got the pandemic sort of epicenter. Who knows what it's endemic in Seattle, it's looking that way. And so if the patient's in Eastern Washington, it just is sort of low hanging fruit to say, you know what, we're going to do, our proactive care management is going to now find you a orthopedic provider in Eastern Washington. Don't come back to Harborview and Seattle, because we think the prevalence of COVID is less and we don't want to risk infection, and et cetera, et cetera. We were also able to articulate team-based ethical deliberations and also stepped provider coping strategies, okay, as part of these sort of rapid sort of logging field notes, team reflection, and rapid crystallization immersion coding. Next month, during the April 2020 surge, we brought in Larry Palankis, who is a trained anthropologist, did the Exxon Valdez. He's worked with Ken Wells' group, is still working with them, and Ben Springate in Louisiana, on various sort of disaster mental health issues. So basically, we had 5 trauma center providers, a trauma surgeon, ED doc, psychiatrist, social worker, and a acute care nurse logging field notes during the April surge. And Larry would do sort of, we don't call them debriefing, but just sort of post-surge interviews, okay? So the kinds of information that comes out of these, heroic phase, if you will, efforts are these sort of decisional algorithms. And one of the bottom lines here, and part of what we were trying to do is get stuff that would sort of maintain itself over the course of the pandemic for our own team's decision making, but also acute care providers nationally. So really the essence of this is there's no easy decision. This is almost like the TSOS team being pulled in 4 directions or drawn in cord. We told our patients, we would be there for them in person and our peers would be there for them in person. And now we're going to have to pull that, especially the peers starting in mid-March. We basically made the peer intervention virtual for a number of reasons, okay? There are considerations related to commitments to physical health. I mean, the rationale for that was many of our peers have either paraplegic or they're aged or they've lost internal organs in a gunshot injury. So they have their own COVID risks, and it's no longer it's no longer within reason to have them for research purposes be exposed to COVID, okay? Any decision like that is you're just pulled in multiple directions, and it seems these type of complex decisions with multiple ethical and collective tensions are just part of being in COVID, right? The other thing we came up with were staged, sort of thought through coping algorithms. First you're thinking about heightening your individual awareness. Am I wearing a mask? Am I washing my hands, for 20 seconds? Am I wearing a mask? Am I wearing goggles? All the sorts of things we've had to change as providers. So it's intense reflection on and awareness of individual routines and activities. You're prioritizing stress reduction activities. You're monitoring social media use. Then you're taking stock of your commitments and ultimately trying to extend yourself without running the gas tank empty to family, friends, colleagues, and community. And, we've tried to, even the social media piece, I mean, there's great data from 9/11 about what it, rewatching, the Twin Tower clips, and now we've got, whether it's, the stuff that was happening earlier this month in the Capitol, there's real advisements that have sort of, I think are relevant, ongoing to our current pandemic and the societal tensions that are coming up around it. So I think we'll stop there. I had wanted to save time for questions, and we'll let Joe field those. We do have a policy summit coming up later this spring, all sorts of interesting things to discuss with the college, and I think that's it. Joe.
Thank you, Dr. Zatzek. Please write your questions into the chat area, and we can go through those. Thank you for presenting today, Dr. Zatzek. It's multiple trials to synthesize with immediate outcomes in changes in practice, looking at ways to test strategies to change practice in large systems, not just with individual patients. Very, very interesting. We'll get the questions coming in soon. I did want to make a note. This is a point that I omitted from the introduction, but given that we've got a minute, I wanted to just point out, I have the opportunity to review CVs of presenters, and I often look at early publications in someone's career, and noted that Dr. Zatzek's first peer-reviewed publication was titled Cultural Variations in Response to Painful Stimuli. And I mean, we've just learned a lot of different research about now interventions for individuals who've experienced painful stimuli. And it's interesting in some ways to see that interest early on in your career as well. So any
no questions. Well, as usual,
no
I probably talk too fast and put too much in front of people.
I can tell you
20 years and 45 minutes, so I apologize for that.
I think it was awkward. I guess one question. Can you talk a bit about developing the population impact, tensions between individual outcomes, population outcomes, how you communicate those tensions and paths forward to hospitals that you're working with?
Well, so those last few slides on COVID, basically, those look like pretty simplistic. We're just sort of on the fly taking field notes and doing qualitative work. Oh, here's something from Rick. Yes.
One comment. Here's a question. There's a couple questions. Let's turf my more abstract question. Here's one. Session-based CBT was pretty much out due to show rates, low show rates. What about virtual visits? Might that be different?
It's a great point. Yes, I think it's often, we have a whole piece on CBT elements. Rick, our population. So, you give them a referral the way we discovered this is Lori Zollner had a trial going on assault victims. And we Amy Wagner and I systematically gave referrals to get to Lori's clinic. And it was really 1 in 100 of our assault victims at Harvard that got there. And we realized that, what our population is like. It's like they have so many competing demands. And then, oh gosh, go to this referral and they don't make the appointment. And they don't for Lori's trial, they don't make the SCID screening appointment. That's the sort of barrier that's going to get you to the treatment, right? We realized that we needed to break it down like MI, we needed to put it in care management. And the first sort of, it's wound care, wet to dry. Like, can you go home and do that? That's actually it's a little bit like behavioral activation, and nurses they're actually much better at that than sort of weighing the pros and cons. So it's sort of like an assignment. Can you go home and change this dressing and call us if you have any questions? So it's sort of like, CBT steps. So that, and the really important thing is that you don't schedule a whole session first, because people miss their sessions, or they can't do the full hour, and then it's just yet another thing that they're not able to do. So we start with sort of CBT elements, and we sort of snowball to, in 2011, it's a great paper, Amy Wagner. We have CBT Readiness Assessments. We're using them a lot now in our sort of comorbid opioid trials, because the substance abuse is a real barrier to CBT entry, and it wasn't really appreciated early on when we were working with Jonathan Bisson and Richard Bryan's protocols. But sort of the construct of CBT readiness, and the notion that the bite-sized delivery of elements sort of gets you ready for the big step, which is the session.
A question came in regarding watching a video of a 30-minute MI interview. Is that available? Do you have any examples that?
Oh gosh, I'm sure we could. The Chris Dunn library is, hopefully we could reach back. I mean, he was just such a master at MI. I defer to him, and there are tons of folks here who, Kevin Hallgreen now I know is I'm working on a trial with him. He's a great CBT trainer. So I defer to that. I did see a debriefing question.
Yeah, that's the next one. Yeah. Let's
sorry, I'll make people dizzy.
I can't keep up with you. All right.
No, it's okay. It's okay. That tends to, let's see if we can go backwards. So this trial was designed to take on debriefing, because remember we're right here. Sorry, don't make people dizzy. So see this. So back in, people are saying, oh my gosh, you just don't want to do anything, and you don't want to force people to discuss their trauma. Okay, so of everything that's happened to you since you're injured, what concerns you the most? Okay, that probe and question, we went with that probe for the first 3 months. Why? Because we wanted, it's entirely inert. I don't know if you know Brett Litz, he's an early intervention. He said, Doug, it's entirely inert. Yes, it's entirely inert. But if you do this for 3 months, patients are totally engaged. You've addressed their biggest concerns, and then you can bring in your evidence-based interventions. Okay, so we know this, that assessing concerns and addressing them does not hurt people. Okay, the other thing we built this is for broad dissemination. So we did disaster work after the Haiti earthquake. Of everything that's happened to you since the earthquake, what concerns you the most? Well, I need a bag of rice. Okay, here's a bag of rice. Well, I need another bag of rice. Okay, here's another bag of rice. Well, the hurricane season is coming, and I need a tent. Okay, here's a tent. Okay, well, we used to have a house, and now we're in this tent encampment, and my daughter comes in, she's 17, she comes in the middle of the night, and I'm worried she's gonna get assaulted. Okay, there's a perfect set of concerns that build sort of from Maslow's hierarchy of needs, from basic concerns to sort of things around safety and PTSD and violence. Okay, it's really an ideal intervention in that you establish a therapeutic alliance, you have folks, and you move through concerns, and you ultimately get to PTSD, depression, sadness, and it really is unbreakable. We used it in the DoD. Since your last deployment, of everything that's happened to you, what concerns you the most? So anyway, that's the diatribe on debriefing. I'll get us back to the end again, so make everyone busy. Joe, other stuff.
Well, can you tell us about medication treatment strategies that you found helpful in the short term, even if it's for symptomatic relief only and not for long-term outcomes in PTSD?
Yeah, I think Jesse's work on SNRIs is fantastic, and we really like the SNRIs, and really are trying to get, because there's peripheral neuropathy is often an issue, in our injured population. So the other thing is we use prazosin, even though there's the New England Journal paper suggesting it's sort of inert, but we still use it, and trazodone frequently. It's sort of, again, Rick is at Harborview, it's sort of, the sleepers are sort of a gateway med, and if we can get sort of early relief in insomnia, then folks are often open to other medications. And in chronically traumatized, 4 serious prior traumas before the event, medications and therapy are key, often. And we often have folks where, no new verbal learning can get laid down. I can think of multiple cases at Harvard. One comes to mind of a guy, a mechanic who engine blows up on him. And he's got multiple burns and polytrauma, and you just cannot even talk to him. If he feels the hot air from a shower, it hits him, he's overwhelmed. Like you can't even begin to talk to him. You need meds, and early pharmacotherapy is really helpful.
It was helpful to see the course of alcohol use on those plots that you described initially from the observational studies.
Yeah. How about, Joe, one thing timely, because you went back to that 1990 article, and I see, junior consult attendings like Dr. De La Rosa, so who are on. I've looked at the participants, and
yes.
Don't worry, I won't call out for it. But so that's a really important finding, because we're looking at disparities these days, and it's such an important issue, healthcare disparities. But in 1994. There's a paper by Todd Knox, in JAMA, It's on long bone pain in emergency department population. Knox and colleagues, they go to the UCLA ED, and they show that Latinx is what we'd say now, or Hispanic populations back in the day, they're getting less opioid pain analgesia for the exact same extremity injury, So here we are, how many, I can't even count it anymore. What are we, 26 or is it 36? 1994, it's 26 years later, and nothing so the disparities are there, and we're going to keep uncovering them, but without a policy lever in your healthcare system, and without the sort of the policy will of decision maker, how are you going to change? It's kind of like, let's look down to what is going to happen after we do all this research. I mean, that finding has been sitting there for 26 years, and I'm sure we could do a bunch of new studies at Harvard, but you really want to look at the policy lever on the other end of something like this, So anyway, maybe we'll call it a day. What time is it? You tell me.
It's 12:57.
Yeah. Anyway, well, thank everybody. Thank you, Joe, for inviting me.
Thank you for presenting, and then we can conclude there.
Okay. All right. Take care, everybody. You know where to find me if you have any follow-up questions. I'm here at Harborview.
Thank you.
Take care.
All right.